Welcome to your renal posting. We've put together this survival guide for what is, let's be honest, one of the trickiest parts of the job, prescribing medications for patients with kidney disease. If you can get this right, you're going to make a huge difference. All right, let's jump right in.
So let's get right to it with a question you're probably going to face on day one. Why can something as simple as a common painkiller, something you've prescribed hundreds of times before, suddenly become a major risk for your patient with kidney disease? Getting this right is literally the difference between helping and harming.
You know, the best way to really learn this stuff is by doing it. So for this explainer, you're not just watching, you're the medical officer on call. We're going to manage a patient, Mr. Tan, together and work through these challenges step by step.
Okay, so let's meet our patient and really get to the heart of the challenge that we're facing.
This is Mr. Tan. He has chronic kidney disease, and his GFR is 25. Now, that number, 25 milliliters per minute, that is the most important piece of information on this slide. Seriously, in renal medicine, the GFR changes everything. It should be the very first thing you calculate for every single patient, every single time. It tells you the kidneys just aren't clearing things, like drugs, the way they're supposed to.
So why does a GFR of 25 matter so much? Well, to prescribe safely for Mr. Tan, we first have to understand how kidney disease completely rewires the way his body handles medication. And this all comes down to something called pharmacokinetics.
Now, don't let that big word scare you. Pharmacokinetics is really just a way of describing how the body acts on a drug. It breaks down into these three key stages: absorption, distribution, and elimination. And in a patient like Mr. Tan, kidney disease messes with all three. But the two we really have to zoom in on are distribution and elimination. Let's take a look. Okay, so let's talk about distribution. Think of it like this. Drugs are cargo, and a protein in the blood called albumin is the truck that carries them. Normally, most of the drug cargo is safely tied to the albumin truck, which keeps it inactive. But in uremia, patients often have less albumin. So what happens? You have way more of this unbound drug floating freely in the blood. That free drug is the active part, and too much of it can cause serious toxicity, especially with drugs like phenytoin and warfarin.
And this brings us to the next huge problem, elimination. When the body breaks down a drug like morphine, it creates these byproducts called metabolites. Now here's the scary part. One of morphine's metabolites is actually more potent than morphine itself. With healthy kidneys, this gets cleared out, no problem. But in Mr. Tan, with his GFR of 25, it just builds up and up, leading to deep sedation and even stopping his breathing. A normal dose becomes a dangerous overdose. Okay, enough theory. Let's get practical. How do we actually put this knowledge into action every single time we write a prescription? Let's build a simple, repeatable safety check that you can use for every single patient. Here it is, your 3-step safety check. It's super simple. 1. Review the patient's entire drug list. You've got to look for interactions. 2. Choose drugs that are kind to the kidneys. Avoid the stuff that's known to cause damage if you can. And 3. Use that GFR you calculated to adjust the dose or how often you give it. You need to make this a habit. Every patient, every drug, every time. All right, back to the word. You get a call from the nurse. Mr. Tan is complaining of really bad joint pain and he needs a painkiller. You've got your 3-step framework in mind, so what are the immediate red flags here? Which common pain meds should you absolutely avoid? So the most important thing is knowing what not to give. This table breaks it down. First up, NSAIDs like diclofenac, they're out. Big risk of causing acute kidney injury. We just talked about morphine and its toxic metabolites, right? So that's a definite no-go. Your safer bets are things like paracetamol or maybe tramadol, but with the dose adjusted. And hey, while we're at it, notice metformin is not here. With a GFR below 30, the risk of lactic acidosis is just too high. Okay, let's fast forward a bit. Mr. Tan's kidney function has declined, and he's now on regular hemodialysis. This adds a whole new layer of complexity to how we prescribe his meds. So how does this machine, which is basically an artificial kidney, change the rules of the game for us? What does it actually do to the drugs that we've prescribed for Mr. Tan?
The whole thing really boils down to this. Which drugs get cleaned out by the dialysis machine, and which ones stick around? Small, water-soluble drugs, they pass right through the filter and are removed from the blood. But bigger drugs, or ones that are really tightly bound to protein, like warfarin and ceftriaxone, they're just too large to get filtered out. They stay in the body. Okay, everyone, listen up, because if you only remember one thing from this section, make it this.
If you give a dialyzable drug before the session, the machine will literally just suck it right out of the patient's blood. Poof! It's like you never even gave the dose. The timing of your dosing is absolutely critical.
And here's what that looks like in the real world. Just look at these common antibiotics. Meropenem, cefazolin, they're typically given 3 times a week, immediately after each dialysis session is over. For a drug like vancomycin, we're even more careful. We'll check a blood level before dialysis to guide our redosing, but we still always give the dose after the session.
We've been through a lot with Mr. Tan, haven't we? So let's boil all of this down to the essential, must-know rules that you need to carry with you every day on your rotation. These are your 4 golden rules. 1. GFR first. Always. No excuses. 2. Review the entire medication list. 3. For your dialysis patients, timing is everything. Dose after the session. And 4, and this is probably the most important one, you are not alone in this. When you're in doubt, just ask. Consult the Renal Drug Handbook, check up to date, and go talk to your friendly renal pharmacist. They are your best resource.
Look, prescribing in renal disease is tricky. There's no doubt about it. But by being systematic and thoughtful, you can absolutely do it safely and effectively. Welcome to the team. We're really glad to have you, and we wish you all the best for your posting here at KTPH.